Apart from that, if ERCP is not feasible, I told you I need to go to the second part of the duodenum. If I'm not being able to, there is gastric outlet obstruction or there is mass at the pylorus. So how can we do the biliary drainage? That's just a brief few slides I'm going to show. Okay, there come the role of EUS, endoscopic ultrasounds. So what we know, look, this is the stomach with the anatomy. The left lobe of the liver is just lying above, or to the right side of the stomach, the whole of the liver is lying. So what we can do, we can go with via our EUS scope, and we can directly assess any part of our liver, and we can directly intervene via the stomach into the liver. So this is also possible. This we are doing it in our hospital, and that's why we have a zero failure cases of biliary drainage in our hospital. If my ERCP is not working, I can directly do it via my EUS scopes. So via the EUS scope, we use the needles. This is known as endoscopic EUS needles. We can go inside the biliary duct and can manage to pass a guide wire to the papilla, or can take even a biopsies. Even if I have the obstruction is here, we can drain it via this left lobe of liver. So one by one, just a brief notations. So there are three routes of biliary drainage. Endoscopically, we can do it via ERCP or a EUS. If everything fails, nothing works, we can do a percutaneous drainage, PTBD. But the most what you call the bad thing with the PTBD is not bad. The demerit of PTBD is the bile is coming out of your system. If bile is coming out, the fat is not going to absorb, and the patient will get emaciated within no time. Okay, because bile is the factor which helps in the emulsification of fat and absorption of that, and you will have fat dependent vitamin absorptions. All will get less. So ERCP, if it is not feasible due to anatomical alterations or inability to assess the papilla, we can do via EUS. So I'm just going to show you. This is a part one. This like we go from stomach to hepatic part. This is known as hepatic ducts. This is known as hepaticogastrostomy. We can do directly hepatic to gastric. Like 2 is by duodenum to choledocho, means CBD, choledocho duodenostomy. 3 is what we are doing day in day out over here in our institute. 3 is we puncture this duct, we pass our guide wire through above downwards. While we are going in ERCP below upwards, this is known as retrograde. We are giving antegrade, and we pass our stent through this. This is a very difficult, one of the most difficult procedures to do in an endoscope, EUS guided, but we are doing it over here. So antegrade stenting is also possible. What is this 4 number? If I am not able to cannulate, not able to pass the guide wire into this, we go through a EUS, we pass a guide wire upside down, and then we take a ERCP scope and go inside. It's like we are putting a central line catheter. Exactly what you do in your ICU setup, you put a catheter via using USG into the internal jugular vein. While I am using all the accessible pathways to put the stent into the biliary duct via any of the routes. The name changes: hepaticogastrostomy, antegrade, choledochoduodenostomy, or it is known as rendezvous, because I am passing a guide wire again going back to it. And even we can assess the any kind of cyst into the pancreatic system. So EUS antegrade stenting, EUS hepaticogastrostomy, or rendezvous methods. So these are the accessories and devices we use to drain our systems, and these are the stent we use to put it over there. It's like putting a central venous catheter into our biliary ducts. Obviously, the stent and the calibers are getting changed. Some of the adverse events can occur, even any of these things. So the take home message I just give you: EUS biliary drainage indicated after failed ERCP. It can be done as a first line procedure if there is malignant distal biliary obstructions, and it is better than PTBD. Many journals and many studies have proven that. And EUS hepaticogastrostomy, I have already told you, if there is no way we can drain it directly to the stomach. It will go to the duodenum and will help you take. So this is our whole team who is working on nearly 1.5 years back. This was the first So cholangioscopic guided stone we have taken out via laser lithotripsy.